The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Thank the organising committee for providing me with the opportunity to speak today, and I'd also like to acknowledge my colleagues who have worked with me on this project. So I've got a background in cardiac surgery, and I've certainly lent on my colleagues for their expertise in terms of MET criteria and the management of MET in this space. So just in terms of some background, in the Australian context, there's about 12,000 patients a year who undergo cardiac surgery. And atrial fibrillation is problematic in between 30 and 40% of those patients, depending on the literature that you refer to. And when we think about atrial fibrillation in the context of cardiac surgery, we talk about it when we're managing it from the perspective of the patient's got a controlled response to their AF, or they're in rapid AF, and often if that's sitting around 120 and less than 140 beats a minute from their ventricular response, hopefully they're not too hemodynamically compromised, and we can have a bit of a look and have some time to manage them. So we also know that just under 80% of patients breach MET criteria prior to, or breach criteria for MET prior to the event happening, and tachycardia is a really common cause for that. Afferent limb failure activation is persistent in this space, and despite that, we also know that if a MET is called, patients will have a decreased rate of mortality, which is can't be emphasised enough. And that's also in the context of cardiac surgery, but the data in the context of cardiac surgery is really sparse. There's not a lot of data around MET management in that space. So the aims of this study, our primary aim was to explore the relationship between breaches between AF, breaches of escalation criteria, and MET activation. And our secondary aims were around determining the frequency of MET breaches in the cardiac surgery population, identifying how many actual activations came as a result of that, and then having a look at the frequency of rapid review breaches as well. So we did a prospective, exploratory, descriptive study where we looked at repeated measures of daily observations. So we had a group of 6 who collected data. We did inter-rater reliability, and each day at a set time we went to the unit and we had a look at every single patient's OBS chart and recorded whether or not they had had a breach of rapid or MET criteria. And we capped it at 9 episodes within a 24-hour period, and that was an arbitrary thing because we didn't think that a patient would possibly have 10 episodes of breaching criteria in that time frame, which was possibly a bit naive. We were in a single site, so a major metropolitan tertiary teaching hospital, which is the largest provider of cardiac surgery in Victoria, and the study had just a QA ethics approval. So we looked at 200 consecutive patients from November 2015 to the end of March 2016, and we had some inclusion criteria, so adult patients over 18, and the patient had to have had cardiopulmonary bypass. Patients were excluded if they died in theatre, if they were in ICU for more than 5 days, and we had this 5-day observation period was not so arbitrary. We selected that because we knew that patients went into rapid AF usually around day 2 to day 4 post-op, and often, most patients have gone into AF by day 5. And we also excluded patients if they got transferred to another unit, which didn't happen often, but sometimes they might get sent out to coronary care. We have fairly standard protocols for the treatment of AF in this hospital. So if a patient's been on a beta blocker pre-op, as soon as they're back on oral fluids, we'll recommence their beta blockade, maintaining electrolyte levels, being sure that the patient's not hypoxic. And if they do go into AF, the standard line of treatment was IV loading with amiodarone, then onto orals, or digoxin. Warfarinization is less common than it used to be prior to discharge, and that's there's some interesting information coming out about that and the implications of that. And DCR, I guess, is also a little bit variable. So previously in our unit we had a dedicated cardiologist many years ago, and for the last probably 10 years we haven't had that. And there's a little bit of tension between having a cardiologist come in to manage an arrhythmia or having the cardiac surgical team manage that problem in that space. So we have, or the hospital has particular criteria around the categories for both MET parameters and rapid response criteria. And they're the criteria that we looked at in this study. So in terms of the cohort characteristics, the 200 patients, they're fairly stock standard cardiac surgical group. So still relatively young, but we do a lot of adult congenital surgery at our centre, so that I think tends to bring the age down a little bit. Most of the patients were male, overweight, bordering on being obese. More than half of them had smoked previously, and we have a high proportion now. We have cardiac surgical candidates are a different population of patients than they were 10 or 15 years ago. If they've got coronary artery disease as their sole primary problem, they've generally had some sort of interventional cardiology take place. So they tend to be in somewhat poorer condition when they do present for surgery. So angina is a problem for a lot of these patients, to the point where they're incapacitated to a certain extent in their activities of daily living or their functional status, and being limited by dyspnea is also a common problem, as indicated by the New York Heart Association classification. When patients are managed from the perspective of their atrial fibrillation, if they come to hospital with a pre-existing history of it, we are aware of that, and we take that into consideration when if they have problems with their AF post-op. So 43 patients in this cohort had pre-existing atrial fibrillation. The surgical stats are fairly stock standard. So an ICU length of stay of 42 hours is often a result of bed block rather than patient need for that sort of length of stay, and the standard deviation's big there. So there's some variability in how long patients do stay in ICU, but often ventilated for sort of 6 to 12 hours post-op. In terms of the post-op characteristics, pretty stock standard too. So 18% of this group had new onset atrial fibrillation. So that's all patients who hadn't had AF pre-op and had developed AF post-operatively. 2 patients had a cardiac arrest. Heart block or bradycardia is a fairly persistent complication after cardiac surgery involving valvular replacement, particularly mitral valve. We had a couple of patients who had a stroke, and the 30-day mortality, we had 1 patient who died in hospital and 2 who died within 30 days post-discharge. There were several patients readmitted in this cohort, which is a little bit higher than our usual rates. But there was a bit of a run of respiratory complications at that time, and I think there was 13 patients came back in with pneumonia or pleural effusion. So in terms of the study that we did, there ended up being 179 patients whose observations were looked at, and in total there was just over 1,700 days of observation included. And you can see here that the average number of times patients were observed was just under 10 times a day. So as Arthur was talking about, I think the nurses, the protocol is after day 2, 4-hourly observations for another 24 hours, but observations were happening much more frequently than that for this group of patients. So in terms of the MET calls, MET parameters were breached 209 times by 72 patients over the 5-day period. So 52 patients breached parameters on consecutive days, so on there was more than a single episode, and there were 16 patients who had breached parameters on multiple days after their stay. there were no patients who had a MET breach every day, which was sort of a relief. And there were 13 MET calls called for 11 patients in this study. So 9 of them within the 5-day period in which we were taking observations, 4 calls after the 5-day period when we had stopped. 1 patient had 2 MET calls on a single day for rapid AF. So in terms of this slide, it's just to give a visual of the number of patients that were observed each day. So the number of patients that had a MET criteria breach and the number of breaches that occurred. And then the same thing for the rapid. So the number of patients that had a rapid breach and then the number of breaches that occurred. And rapid criteria were obviously problematic, particularly on day 2 in this cohort. If we think about it as a proportion of the total number of observations that were taken, less than 5% of the breaches were for MET criteria, but we're looking at around 1 in 5 sets of observations had a breach related to rapid criteria, so it's pretty frequent. And if we think about what those criteria were that caused those breaches, in the rapid space it was around oxygen saturation, hypotension was a problem, and then heart rate. But variability depending on which day, and of course day 1 is the first day of transfer to the step-down unit, so not day 1 post-op. It was usually day 2 post-op. With the MET breaches, heart rate was most problematic on day 3 and day 2, as was expected. So in terms of the AF, in total there were 72 patients that had a problem with atrial fibrillation out of the 179, and over 50% of the MET heart rate breaches were caused by half of these AF patients. So clearly the patients with atrial fibrillation are a problem for management in this space. So 30% of them had pre-op AF, and then it's become problematic again post-operatively. Sometimes patients come back in sinus rhythm, but not usually. And most of the patients who were having AF were patients with new AF who were breaching heart rate criteria. So patients with atrial fibrillation were responsible, 5 of them were responsible for the MET calls, and a fairly large proportion of these patients remained in AF at the time of discharge. So in terms of our conclusions, day 2 to 3 after transfer to the step-down unit were the peak times for problems in terms of criteria breach. On day 2 it was because of SATs and low BP, and on day 3 it was because of elevated heart rate. So if we're thinking about the observations, it was a small proportion of patients that were breaching, that were breaching criteria in their observations, and a small number of patients were having a MET call called or having MET activation put into place, in contrast to the number of patients that were breaching the criteria. So over 50% of the breaches were the result of AF, and half of the AF patients had a MET heart rate breach, leading to a MET call. So overall, escalation criteria are frequently breached after cardiac surgery, and the rates of escalation are clearly inconsistent with the guidelines and hospital policies. The rate of MET activation in this cohort was even lower than the rate of MET activation in general surgical populations. And I think in the future we need to think about looking at the sensitivity of rapid review criteria. I suspect that if you're taking that many sets of observations and you're seeing rapid breaches happen that often, perhaps you become desensitised. I'm not sure what's happening at the bedside there in terms of not escalating those criteria. We need to be vigilant in our management of AF, and I think it would be useful to explore the interplay between rapid criteria as a precursor to perhaps going the next step and then breaching MET criteria. So there are certain antecedents that we can look for when we're looking after patients with atrial fibrillation, and keeping an eye out to see whether or not they're appearing might help us to reduce the rate of MET breaches.